Good evening all to the 100th session of the Weekly Huddle. Most of you have been either a regular visitor of the huddle or have attended the session at least once. The model has been described for quite a few episodes, and it is my pleasure to host this meeting, knowing that at least we have continued for 100 episodes. Every single of these sessions was joined by my colleague and co-host Praneeth, who had been there since the very onset of this program, right from its designing to conceptualization to execution. And pretty much we both have been doing it for the past 100 episodes. The first 8 sessions were not recorded because at that time we didn't have the plan to record it and put it in a formal database. But from session 9 onwards has been recorded, and we upload them time and again on YouTube and on podcast for people to consume offline, as to speak, that outside of the live discussion. I did start a WhatsApp group about 50 episodes earlier, and that WhatsApp group was meant for those people who wanted to be associated with the Weekly Huddle. I must say that since the starting of that WhatsApp group, I personally have not added a single member. It was 100% voluntary, as in the links were sent to our friends and colleagues. And voluntarily people joined on that Weekly Huddle WhatsApp group, where we do discuss these clinical topics outside of the live discussion. And also we post the updates on the Weekly Huddle. That is pretty much the purpose of the Huddle WhatsApp group. What's interesting is that over the time, the total number of members in the Huddle group kept increasing to the existing day, where we have 252 members on our Weekly Huddle WhatsApp group. To give you a perspective, that is about the same number of doctors as what we have on our Telangana CSI WhatsApp group, or the Eosinophilia alumni WhatsApp group that I'm a part of. But as the WhatsApp group membership kept increasing, our overall attendance on the live discussion kept decreasing, almost like the Weekly Huddle is on a weight loss over the last few weeks in terms of live attendance. Having said that, we continued our discussion, and here we are at our 100th episode. I am hosting this session from Paris, where I am attending the EuroPCR. It's 3:30 p.m. here right now, and I take pride in doing this. Having said that, we are going to start our today's discussion. Today's discussion is about a clinical scenario which I used to at least encounter quite frequently during my childhood and early MBBS days. I really didn't know what to do with it. And now, after 15, 20 years, particularly being in the field of medicine, I still don't know what to do with this. And there are differences in opinion, both in terms of physicians as well as general practitioners, in terms of how to handle this particular situation that we are discussing today. So we'll try to make it a more practical way of addressing how we should interpret eosinophil counts in our routine blood work, more emphasizing more on the non-oncology aspect of it. I want to restrict the discussion to not include those hypereosinophilic syndromes which get onto the oncology aspect, except understanding when we should be thinking of malignancies related to eosinophils. So with this little update and little introduction, today's case is about a 46-year-old male. He is sedentary in his life. He does have a shop that he owns, but his overall physical activity is very minimum. He actually got a master health checkup done recently. And as a part of master health checkup, he is seeing me as a cardiologist for cardiology opinion. On poking, he says he gets tired easily. He has got this exertional fatigue. He did say that it feels like short of breath, but he hasn't really paid attention to. And he has been having these symptoms for quite some time. He is a little bit overweight. His BMI is of the order of 28, 29. And as I said, he is sedentary in his lifestyle. In his routine workup, most of the numbers were normal. I'm not highlighting those numbers. You all know what a typical master health checkup includes, except a hemogram, which has got 12% eosinophils. The absolute number was 1,100. You can guess the TLC count was probably around 10,000 or so. The rest of his parameters, as I said, were normal, and he didn't have any other major complaints. He's non-diabetic, non-smoker. He is a vegetarian by diet. And I already told you, he's a shop owner. He owns a small shop where he goes to his work daily, and he takes his motorcycle up to there. His daily activity is quite minimal. So the discussion that we are going to talk around is how to interpret these kind of eosinophil numbers in routine assessment. The points that I want to cover is what is the eosinophil value beyond which we should be acting, up to what point we can ignore it. Hypereosinophilic syndromes that we identify in our common clinical practice, is there a way for a cardiologist or a physician to differentiate between what is a more benign number versus what is a more threatening or a malignant number that we can act upon? Should we ignore a lot of these numbers, even if they are high, or should we do any further diagnostics? And is there a role of any empiric antiparasitic drugs or any other therapy? And the reason why I included this last line is because I have seen the empiric treatment options spanning from anything to anything. You just name it, and I have seen doctors in their best practice prescribing these medications, knowing that these occult diseases could be the one responsible for this hypereosinophilia. So with this background, I will start with Praneeth. I always, as a customary, ask Praneeth to give his opinion, and then we will ask opinion from rest of our attendees. To facilitate the discussion, we are joined with Dr. Guru Prasad. He is an internal medicine physician at Care Hospital. He has been at Huddle before, and we will take his opinion as well once we hear from our attendees. So Praneeth, floor is yours. You take up this case.
Yeah, good evening, everyone. As you said, Anup, it is equally a gray area for me as well about evaluation and interpreting these numbers. The thought process which I have is that any eosinophil count which is more than 500, absolute eosinophil count, is something significant, and any count more than 1500 is something which is like which can be associated with hypereosinophilic syndromes. Now, this patient is apparently asymptomatic, and his symptoms probably looks more related to his physical deconditioning, and his obesity probably may not be related to the eosinophil count. So this is an incidental finding that we found out in master health checkup. The two common things that I think will be contributing to increased eosinophils is the history of any allergic airway disease. So maybe I would ask this patient whether he has any symptoms of wheezing, sneezing, any dryness of throat, itching of eyes, something like that. So those are the things which I can kind of attribute these findings to that. And maybe parasitic infestations, again, if he does not have any anemia or any other findings of passing worms in the stools or etc., again, less likely to be explaining the cause. Any what do you call those myeloproliferative disorders, something like those could be other possibility which my understanding or knowledge in evaluation is limited. Regarding treatment, empirical anti-parasitic agents, I am not comfortable or I haven't practiced any time. The one thing which when I do give empiric antiparasitic is in terms of anemia. Other than that, for eosinophilia, I have never prescribed, so I am not comfortable prescribing any. I am eager to know. And evaluating eosinophilia is again something which is uncomfortable thing. For majority, if the counts are low, you kind of reassure the patient because they're asymptomatic and kind of ignore most of the time. But these numbers, 1,000 is something which is not a number which you can equally ignore. So I would suggest him to see a physician for evaluation in this regard. My evaluation per se is limited other than what I said before.
So, Praneeth, just one thing you mentioned about asking the history of reactive airway disease like allergic rhinitis, breathing difficulty, whatnot, and all this. My question to you is, and this is the same question I have it in my mind, it's chicken and egg. A person who has got high eosinophil count, is it that it is the allergic airway disease which is causing high eosinophil count, or is it something else which is causing high eosinophil count and leading to this kind of allergic phenomena? Is there a way to differentiate? Do you know, or how do you work?
Not so confident enough. I believe it's probably allergic airway disease which is contributing to high eosinophil count. The issue of eosinophil counts as a cause of wheezing or bronchospasm, I believe that should be as a presentation of hypereosinophilic syndrome where the count should be even higher than what you mentioned. So in this case, probably I believe is maybe associated with allergic airway disease, but I'm not sure. I'm here to learn.
Thank you, Praneeth. Before I go to Shankar sir, I will ask Vijay Reddy sir. Sir, if you can hear me, could you please unmute yourself and share your experience with high eosinophil count in your patient subset? Are you sending those patients to a specialist, or you are doing a preliminary assessment? And till what point you ignore these numbers?
Good evening, everybody. See, eosinophilia, most of the times we are seeing in bronchospastic conditions and allergic diseases, and parasitic infections also we are seeing very commonly. And we are not seeing very high eosinophil in our practice, more than 1,500. If I find such patients, immediately I refer to the physician for further evaluation.
Thank you so much, sir. I will ask Shankar sir to give a rundown on how we should be looking at, or how he thinks when he sees a patient like this. Particularly, sir, I want you to emphasize upon the non-oncology aspect of it, and what empiric treatment do you give to these patients?
Good evening to all. Good evening to all. My heartfelt congratulations to Dr. Anup Agarwal and Dr. Praneeth for conducting 100th session of Weekly Huddle. Before we come to the part of eosinophils, the eosinophils are predominantly, they are tissue-dwelling cells. Though they are seen in the peripheral blood, but they are tissue-dwelling cells whose function in the health are not entirely understood so far. But eosinophil numbers, they increase in a variety of disease states, ranging in severity from mild to life-threatening, as just now Dr. Anup alluded to. So when these activated eosinophils, they release mediators and also some substances that will damage the tissues and contribute to disease pathology. So coming to the basics, we see in the hemogram that WBC count and percentage of eosinophils. But For all practical purposes, it is better to find out what is the absolute eosinophil count. That we will get by multiplying this WBC count, total WBC count, into percentage of eosinophils, so that we will get number of cells. Normally, the normal values of these eosinophils are 0 to 500 cells per microliter. When this more than 500, if you see in the absolute eosinophil count, we say that it is hypereosinophilia, more than 1500 cells. Then hypereosinophilic syndromes, when do we say the absolute eosinophil count is more than 1500 cells per microliter, as well as there is a organ dysfunction. If there is a definite organ dysfunction is there, we say that it is a life-threatening conditions most of the times. That is my hypereosinophilic syndrome. The major causes of eosinophilia, what we see in our clinical practice, the multiple organs are affected, accompanying the peripheral blood eosinophilia. Then we should, in that allergic disorders, as Dr. Praneeth is alluded to also, that allergic disorders, especially the skin allergies, the drug, especially the drug hypersensitivity, that history has to be taken. Then infectious diseases, amongst them parasitic infections, fungi, protozoan, sometimes even HIV viral also. Then third one is the neoplastic disorders. Either we should think of a eosinophilic leukemia or a myeloid series, or sometimes even the eosinophilic neoplastic disorders, we will think. Then immunological disorders, eosinophilic disorders, especially that is eosinophilic granulomatosis with the polyangiitis. Most of the times we see in our clinical practice when the patient comes with frequent bronchospasm. So Churg-Strauss syndrome, we think. And when we come across GERD, gastroesophageal reflux disease, and if we take a biopsy, sometimes it will reveal eosinophilic esophagitis. So these are the common conditions we will see in our clinical practice. Commonly, they are mostly drug hypersensitivity, helminthic infections, and neoplastic disorders. So these are the common conditions where we get a eosinophilia. And the second thing is, this eosinophilia is associated with some organ restriction is there. Only there is the involvement of a single organ. Like skin is there, atopic dermatitis or allergic dermatosis. There may be sinonasal and the pulmonary allergic rhinitis, asthma. Then the GI disease, just now I mentioned the eosinophilic gastritis, esophagitis, so eosinophilic diarrhea also. The neurological diseases like is eosinophilic meningitis, rheumatological diseases like vasculitis. So cardiac diseases like eosinophilic myocarditis, that may lead to eosinophilic this heart failure also. So eosinophilic myocarditis. So the specific organs are involved in the associated with the eosinophilia. Then having said that the multiple organs are affected and a single organ is affected along with the peripheral blood eosinophilia, then the hypereosinophilic syndromes where the absolute eosinophil count is more than 1500 cells per microliter, along with the organ dysfunction. If it is there, we say that it is a hypereosinophilic syndrome, and especially it is a primary or neoplastic, myeloid or eosinophilic. If it may be secondary or reactive, that is maybe due to parasitic infections, solid tumors, and T-cell lymphoma, etc., etc. And idiopathic hypereosinophilic syndrome, where we don't find either neoplastic or reactive causes, then we say that it is idiopathic. And specific syndromes also there mentioned. That is just now we talked about Churg-Strauss syndrome, EZPA, that is eosinophilic granulomatosis with polyangiitis, autosomal dominant hyperimmunoglobulin E syndrome, that is immunodeficiency syndromes. There we'll see the hypereosinophilia, where more than 1500 eosinophilic count, eosinophils per microliter. And primary disorders of the phagocyte, either number or function. These are common hypereosinophilic syndromes, primary, secondary, idiopathic, and specific syndromes. So in this case, the patient has got 1100, absolute eosinophil count is 1100, and mostly our area is endemic for helminthic infections. So the commonest helminthic infections, the pinworm, the threadworms, sometimes roundworms. So strangulidosis also, when we come in contact with the soil, especially farmers and all. So, so broad spectrum anti-helminthic drug we give, that is albendazole, that is 400 milligrams, a single dose. Or if the strangulidosis, stercoralis is suspected, we can add ivermectin also. But one word of caution, when we give ivermectin, especially in Central Africa and African countries, where the loba is endemic there. That's why if we give ivermectin there, that will lead to encephalopathy. So especially in African countries, the ivermectin should not be given because of lobosis. So this is my approach towards eosinophilia. Then eosinophilia, the causes, the multiple organs and the single organ involvement, the conditions I enumerated, and if the organ dysfunction is there, like skin, lungs, GI tract or nervous system or heart is there, then we think of hyper eosinophilic syndromes, and we, if dire emergencies are there, we give, if the patient comes with some level markedly ill and comatose or dyspneic, then we resort to glucocorticoids. Sometimes the glucocorticoid sparing agents like mycophenolate, mofetil, those can be given. This is my approach, and if hematologists or those who are well versed in the hematology, they can enlighten me in this regard, regarding the eosinophilic leukemias and the myeloid series, how we approach myelomonocytic leukemias. So many, that is the neoplastic itself is a different topic. We leave it to hematologists. So thank you one and all.
So Shankar sir, question to you is, when these kind of patients, when they come to you, do you do any kind of investigations, or you first try empiric anti-parasitic drug, knowing that we are in an endemic zone? What do you typically do?
What are the symptoms the patient present with? We'll see. Then suppose the patient comes with the cough, dry hacking cough, and wheeze is there, then we'll investigate in a different way. If the patient comes with a rash, then we take history of skin allergy because of any drugs, so drug hypersensitivity. So Depending on the organ involvement, we'll investigate further.
Thank you so much, sir. I will ask Guru sir to give his thought. So, Guru sir, here is this scenario. We have a patient who is 46-year-old, otherwise asymptomatic or at least minimally symptomatic. He says exertional discomfort, which could very well be deconditioning, as what Praneeth was mentioning. Absolute eosinophil numbers, which are not terribly high, but they are definitely higher than normal. And it is that black bold letter on the report printout that the patient is staring at, and you are staring at both. And this patient is sitting in my cardiology clinic. How should I go about it? Should I put him on therapy? Should I send him to you? Or should I send him to a hemonc? How do you look at this particular case and hypereosinophilia as a general? Guru Prasad sir, all yours.
Yeah, thank you, and congratulations to you and Praneeth who have hosting this sessions. This is the 100th week, and I'm really congratulate you both. Regarding coming to this topic, this has been a very common confusion among people how to approach a patient with hypereosinophilia. But it's first important to understand that what is exactly hypereosinophilia. So many of the times we find eosinophil counts in the range of below 1,500. It is called mild hypereosinophilia. Moderate is in the 1,000, but the count is between 1,500 to 5,000, and severe is it's more than 5,000. There's a classification of hypereosinophilia, as you put it. So any patient with less than 1,500 counts, I would not really subject him to many investigations. Hello, yeah, can you hear me?
Yes, we can hear you. Yes, for a moment we lost you, but we can hear you now.
Anup, can you hear me?
Yes, sir, we can hear you.
Guru sir, we are able to hear you. I think he has a network issue.
Guru sir, you seem to be unmuted. You seem to be muted. Yeah, can you please speak something? Can you say something?
There seems to be a technical glitch. He logged off. He'll be probably logging in again.
So while he logs in back, Praneeth, the whole idea, I remember earlier we were talking about empiric deworming in Indian subset, knowing that we are in a pandemic zone. Is that or endemic zone? Is that something which is still valid? Are you in your local patients? Are you advocating doing empiric deworming every 6 months or 1 year or something like that?
No, I am not doing it, but I believe probably it makes sense. It's just that you don't have enough confidence or a protocol to do it, and I think it is all individual practice. Persons who believe it are probably doing it. Or at least we are practicing it probably in urban part of the city. So I don't think this is quite common, but maybe still wrong. At least I'm not practicing it.
Guru sir, are you logged in back again?
Yeah, logging back. Actually, there's some problem. So sorry with the connection.
Okay, not
So
at all.
I
Please,
would catch the last part of Praneeth's conversation, and I would like to tell you that there is actually an index given for hookworm infestation in India. It's called the Chandler's Index. So it's the amount of ovas and cysts you pass out of the hookworm, and that's how endemic it is in our country. That they have to actually classify the burden of the hookworm. So I don't think we are wrong in empirically giving a drug like albendazole empirically. It doesn't cause much harm apart from causing little, kind of cramps in the tummy after you take it. And some people complain of giddiness. That's why we give it at bedtime. So it's very safe to give an empirical albendazole and not overtly investigate a patient with mild hypereosinophilia. Where you tend to investigate is a person who is like coming with probably other symptoms which I suggest. So let me come to the cause of eosinophilia. One is most common is parasitic infections, as someone was telling. Anup, can you hear me?
Yes, sir. Yes, we can hear you.
So apart from coccidioidomycosis, none of the other fungals will cause hypereosinophilia. Other thing which we commonly see in our country is allergic bronchopulmonary aspergillosis, ABPA. So there the patient will come with different. Hello.
Yeah, Guru sir, for some reason you keep getting muted for some reason. It's automatically getting muted. All right, looks like this is going to be one of the day where we are challenged with technical issues. While Guru sir is logging back again, if anybody has got any thoughts to share or any questions, they can unmute themselves. Okay, we are still waiting for Guru sir to log in.
Yeah. So I was just trying to complete my this thing. So in rheumatological disorders, you have rheumatoid arthritis and palliative nodosa, Church syndrome. That's cause of eosinophilia. And apart from these, you have the monoclonal anticoagulant like eosinophilic leukemias or something like hypereosinophilic syndromes. According to WHO, now hypereosinophilic syndrome is actually a secondary diagnosis, and you should not diagnose the patient primarily as hypereosinophilic syndrome. So we should look dedicatedly for a reversible cause of hypereosinophilia before labeling a patient as hypereosinophilic syndrome. Uh, so I mean, there can be myriad reasons for eosinophilia to occur, and we should, in our country, I think the most common is still parasites. Second, there's a different entity called tropical pulmonary eosinophilia, where people have feeding infiltrates, they are infected with microfilaria, and they get this intermittent episodes of bronchospasm and cough. So that's also pretty common, condition in our country. It responds well to a drug called hetrazan. I think all of you know about it. I think uh, for us, the threshold for really investigating a patient aggressively should be more than 5,000 eosinophils or eosinophilia with organ dysfunction, or probably a rash which looks like a vasculitic rash, or there is definitive evidence of lung involvement or cardiac involvement or any other visceral involvement is there to suspect a secondary cause of eosinophilia. So I would, in my clinical practice, would probably this patient, the index case which we're talking about, would deworm the patient first with a broad spectrum antipyretic like albendazole with ivermectin. And there are a lot of medicines which are available over the counter which combine these two drugs, and probably repeat the eosinophil count after a couple of days, probably a month's time or so, and then take it from there.
So, Guru sir, question for you: this hetrazan that you mentioned, I remember early on there were a lot of doctors prescribing it empirically, and then I saw a lot of doctors not prescribing it now. Was you briefly mentioned the rationale? Could you please elaborate on that? Why was it prescribed, and why we are not seeing that kind of prescription these days?
We're not seeing, but the people are not aware of it. So, I mean, there's something like an overkill nowadays in terms of investigations. Probably, I think that's what I'm saying. You need to understand which country you are in and what is the endemicity of a disease in a particular scenario. So, I still would say, suppose a patient is from the either East Godavari or West Godavari district, where filariasis is endemic, and the patient comes with typical fleeting infiltrates, history of something like a bronchospastic cough with eosinophilia. I would think of it as a common and probably give hetrazan as a course, and also would look at, you said in this index case that, for example, this patient is a shopkeeper, right? So he's a shopkeeper, no? Hello?
Yes, sir. Yes, sir.
So what shopkeeper is also important. If he deals with books, so books tend to attract, because they are organic material, they tend to attract aspergillus molds. So aspergillosis, ABPA would be something. He would be having fungal sinusitis and aspergillus sinusitis, which is, and he may not have the typical symptoms of cold and everything. it will just manifest as fatigue. So that peripheral eosinophilia might be because of some aspergillus causing hypersensitivity. So aspergillus are the different types, by the way. All need not be pneumonias or ABPA. There's something called hypersensitivity to aspergillus, so which can just present as simple fatigue and some kind of a dry cough, and the patient has some hives or something coming up. And when you take the history, they will actually have a home which is leaking, and they have molds at home, or they have old books in a library which harbors aspergillus spores. Especially when you are doing renovation of home and you are dealing with old furniture, aspergillus becomes very common. So, I mean, eosinophilia is a very broad topic, and unless until the eosinophil count is more than probably 1,500, you really don't have to really think about it too much in terms of investigation. Just deworm the patient and repeat his eosinophil count after a month's time, and I think it should be fine.
So tell me about these allergic components in eosinophilia, because a lot of patients, like for example, I have reactive, I shouldn't say reactive airway disease, this atopic dermatitis, where a lot of these syndromes, they kind of come together. We have patients who have allergic rhinitis, urticaria, and this conglomerate of milder versions of these immunological diseases, which also includes some bronchospastic component, not in all of them, like I don't have a bronchospastic component. In all of these patients who do have some sort of allergy to something, we don't know what, but otherwise not affecting their major organic life, in those patients, do we expect eosinophil count to be high? Do we expect them to be high for a long period of time? Or we should investigate if EOs are high at some point? Like, how do we take it further?
So there's a very interesting entity among cardiology patients that they have aspirin sensitivity and they might have allergic rhinitis and nasal polyposis and a bronchospastic disease. So that's a typical entity where you have aspirin sensitivity. Okay, I'm little deviating from the question which you asked, but I want our cardiologists to be aware of this aspect of where there is aspirin sensitivity with nasal polyposis, allergic rhinitis, and bronchospastic disease. Coming to your point that you have a history of allergy and you don't know when to investigate. So basically, allergy is a very broad phenomenon. There are immunologists who have done a lot of studies on allergy. There are a lot of theories which have been presenting this forum is like you have two sort of time to discuss about it. But there are skill tests which are available and whose relevance is still not really known in clinical practice. They'll say you're allergic to cockroach or some vague thing which the report will come in the skill test report. But how to react to it is something which we only have to interpret and think about it, how to react to it. But to put it in a practical perspective, I think some people ask for IgE levels. I'm not really sure to diagnose what, because eosinophil counts for high, IgE levels are going to be high. So IgE levels are to be done only if you're suspecting probably in a patient who is having severe rashes, eosinophil counts are normal, you're suspecting systemic mastocytosis, then IgE levels help. Or you're planning for a therapy of like omalizumab to be given to a patient, then IgE levels serve as a marker to look at your response to the treatment. So most of the time for a patient with a history of recurrent allergies and cold and cough, I would actually, if the eosinophil counts are persistently above 1,500, I would ask for probably a CT-PNS to look at polyposis or evidence of any aspergillus colonization, and treat accordingly and take it forward from there.
Sir, in the current era, how frequently you end up doing stool analysis for these kind of patients, or you think an empiric treatment is the way to go?
In this past 6 years in care, only once have I found a patient. Actually, it was a very interesting case. He was a farmer who came with severe muscle pains and back pain and everything, all those things. And eventually, he had severe anemia. His stool examination was normal 2-3 times. But we did an endoscopy and pulled out a worm actually from his duodenum. So, stool examination is extremely subjective. There is no objective criteria to examining a stool. So the pathologist will see what he knows to see, right? And we have to believe it. So till now, I've not seen a positive report for a stool for ova and cyst. But yeah, I mean, in my college days, I've seen a couple of stool examinations which have come positive for either Escherichiasis or hookworm.
Because I believe so. What you gave an example of endoscopy pulling out a worm, that certainly has to be one in a lifetime or something of that sort.
Yes, it was. It was.
And I also believe that our MBBS education of taking the history where a patient says that there are worms coming out of my anus or stool, I believe that also will be historical, right? I don't think that these days we are having that kind of clinical presentation, or maybe I'm too urban. What do you think? Do we see these kind of presentations?
Most of the times we have Western commodes where you really cannot see your stool, right? I mean, it's the stool has sunk into it. So we had Indian toilets before where you could see your stool clearly, and the worms coming out of it.
But if the worm comes out, you would still see it, no, or at least feel it, no? I don't know. I don't know how to see the worm.
Probably the worms are drowning in the Western commode. I don't know. We are not seeing it. That history is not there anymore. Or I believe people are not asking for that history anymore. But yeah, in our country, Anup, to underlining, because it's a big forum and like apart from jokes, I think deworming should be a norm in everybody. We deworm children. Pediatricians deworm children left, right, and center. But in adults, somehow there is some kind of either knowledge is not there about the endemicity of parasitic infections in our country. Somehow that is lacking. A lot of patients with iron deficiency anemia keep coming back with iron deficiency anemia. They are subjected to endoscopy, colonoscopy, CT abdomen. Everything comes out to be normal, and you develop them appropriately, and their actually anemia settles down. I've had a couple of cases like this where we were kind of groping in the dark for the cause of anemia, where the gastroenterologists were groping in the dark by doing endoscopies, colonoscopies, capsule endoscopies, CT abdomen. Everything was normal. So the worms were not picked up by all these things, no? So eventually we dewormed the patient and the patient was fine. He didn't require any more transfusions or iron supplementation subsequently.
And Guru said, last questions, just like we have serological data for H. pylori and for others, I believe, do we have some kind of serology assessment for parasitic infections as well, or any kind of intestinal infection?
I believe there is, I'm not really sure, Anu, but actually in stool, to be very honest, there's a technique called the Cato-Cats method where you concentrate the stool repeatedly to get the ova and cysts out. Recently, we convinced our department to start doing that technique. Dr. Jhansi to do the technique to pick up this thing. But as far as I understand, there is no, we have Entamoeba histolytica, this thing, serology. For microfilaria, we have histology. Microfilaria antigen is there. But unfortunately for parasites, there is nothing like a serological diagnosis, because you rely the fight of the body towards the parasite is from IgE. So ELISA doesn't detect IgE levels. So in the sense that there is no ELISA technique to detect the antibody which are IgE and which form the antibodies against this particular parasite. So we don't have a serological marker, unfortunately.
And sir, at what levels or at what eosinophilin numbers we should be suspecting cancer? I know the
more than 5,000. More than
5,000.
Yes, so that is severe eosinophilia. So if a patient comes to you with Anup with more than 5,000 eosinophil counts, apart from again deworming him, I would suggest that there is something called a JAK analysis. Okay, so it can be myeloproliferative with JAK2 mutation positive. And there is something called a PGDR-A mutation, PGDR-B mutation. Basically, it is to understand you have to give hydroxyurea or imatinib, as far as my memory serves, right? Please correct me if I'm wrong, if any hematologist is there. But this is what I remember out of my whatever I read about eosinophilia some time back. So this level comes, this comes only if the eosinophil counts are more than 5,000, where you suspect either systemic mastocytosis or eosinophilic leukemias or myeloproliferative kind of eosinophilic malignancies, which are very, very rare, in fact. So I think that is when that workup should start. And also one more thing I would also like to tell you is there's an entity called IgG4 disease, okay, which also presents as allergic symptoms, as allergic rhinitis, as nasal polyps, and the patients have
pseudotumors, and they have what we used to term as Mikulicz syndrome earlier is IG4 disease. So if you see Harrison, he says that IG4 disease is a mimic. It's actually called a great masquerader. And it masquerades a lot of tumors or other things in the body. In cardiologists, it presents as pericarditis, pericardial involvement, myocarditis, sometimes aortitis. And these patients actually have eosinophilia, and they present as allergies, basically. Allergic rhinitis, tearing from the eyes, nasal polyposis, sinusitis, and they actually turn out to have IG4 disease.
Perfect. Thank you so much, Guru Prasad sir. If anybody has got any questions for Guru sir regarding hypereosinophilia, you can raise your hand or put it in the chat box. I will request Somaraju sir to give his opinion about today's topic and anything that we missed. Somaraju sir.
Thank you, Anuj and Pranit and everybody, and congratulations for scoring a century. Not out. It was a very educative overall sessions. Whatever I attended, it's a very good effort at continuing education. Having said that, coming to eosinophilia in relation to practice of cardiology, apart from many other things that are already said, you must keep in mind that patients who have a prosthetic valve or structural heart disease, they come with recurrent thrombosis, you must rule out underlying eosinophilia. You must keep that in mind. And various vasculitis syndromes, some of it are already covered. But I have to re-emphasize the eosinophilia and tendency for thrombosis and structural heart defects, and also particularly prosthetic valves. Thank you.
So, sir, is it the high eosinophil count which is leading to thrombosis, or they are kind of the byproduct of something else missing, like some malignancy or somewhere, whatnot?
Our patients we saw, it was eosinophilia responsible actually for a tendency for thrombosis. And we have seen, nearly half a dozen patients in the last few years. Some of them are very young, and many of our colleagues are aware of it actually.
Sir, there is one question which is relevant to you rather than any one of us having a direct experience. I remember back in the day, there was a lot of research going on in terms of what kind of metal to use for stents, particularly coronary stents. And nickel was one of the prominent material. Even now, there are certain structural heart valves where nickel is a predominant component, like my valve, for example. And we hear these stories about patients developing nickel allergies once the implant has been placed. Have you personally encountered these kind of scenarios of nickel allergy presenting as hypereosinophilia or anything of that sort? Somaraju sir?
Yes, you are right. It can happen, and there is another. There is an entity called Cohen's syndrome. Cohen's syndrome, allergy to stent material, and results in thrombosis, etc. It is well described actually, and you have to keep that in mind whenever a patient with stent has a tendency for thrombosis and eosinophilia, etc. Eosinophil counts will be raised in some of them.
So, sir, those patients, they end up getting their stent explanted, or do they settle down over the period of time? What happens?
We at least we thought we saw two patients, and we didn't take out. There was no attempt to take out the stent, and then they did respond to routine measures. In one of them, we gave steroids also, and they settled down. But there was stent thrombosis. There was acute myocardial injury, etc.
So this point basically needs to be refreshed because, as I said, there are larger valves, but there are larger devices, particularly heart valves, and then there are self-expandable devices, all of which have got nickel as a component. And if we see anything from our past, patients, while they are in small numbers, they do have allergies to nickel. Very recently, one of my colleagues, he had a patient where a TAVR valve was implanted. And post-TAVR, the patient had fever going on for close to 2 to 3 months, for which pretty much every single workup known to mankind was coming negative. And one of the working hypotheses was that he probably developed allergy to the metal, which was a part of the valve. And this particular valve was made up of nickel and cobalt. And cobalt is more tolerated in our body than nickel. So it was assumed that this gentleman had nickel allergy. The fever had a roller coaster run for about 2 to 3 months, I believe, and slowly it settled down. So while we don't have a definitive diagnosis, the working diagnosis is a metal allergy. I don't know what his eosinophil counts were. It would be interesting to see what those counts were, at least for the academic sake. I don't have those numbers with me. But at least from the cardiology aspect, device allergies should also be kept in mind when we are dealing with these parameters. Anybody else?
Arun, Dr. Anup,
Yes,
while you are on these things, I just have to mention the issue related to intestinal worms and passing of worms in the stool. It depends upon where you practice. If you have a patient coming from Godavari districts, the patient is a farmer or agricultural worker. Many of them don't wear a footwear, and then they go around on bare feet, and intestinal or hookworm infection is still particularly common. If you ask their history, some of them do come out clearly that they passed worms.
interesting, sir. I think what you said is correct. Part of us getting a different set of patient altogether, maybe because of the urban population that we cater to for most part. I'm sure that the doctors who are practicing in more rural areas, they do have a different experience than ours when it comes to intestinal infections. Shankar sir, you have something to add?
Ours is an endemic area for these parasitic infections. But I have seen many cases in our area, the tapeworm infestation. The patient complained of some scaly or sometimes the seed-like things passing out in the stools. So I asked him to bring the stool for specimen, and I could find out the segments of the tapeworm. Then we gave praziquantel. Actually, it is not freely available here. I got it from More Medical from Hyderabad. Then I gave a single dose. The patient has passed some, we can measure it. It was in meters. So we showed it to our juniors also in the IMA. So recently we have seen 2 cases of this tapeworm infestation that whenever the patient complains that he passes some seed-like things or some scales, then we should ask them to bring the sample and the stool specimen, and let us give a trial of praziquantel. Then so why praziquantel advantage over the niclosamide is this niclosamide, it dissolves the head of the tapeworm. That's why. So here, with the praziquantel, along with the head, entire body and the everything will come out. So that is the advantage of the praziquantel, and it will be available even in Hyderabad, freely available in very few shops. That is a More Medical in Bashirwa. So we gave it. We in 2 cases we got success with the expulsion of this tapeworm. So we should keep in mind when we are talking about the parasitic infestations. So this tapeworm is also quite common, the Taenia solium and the Taenia saginata, in the beef and the pork eaters.
Thank you, sir, for that interesting insight on the tapeworm infection. This is something that definitely we should keep in mind, even if we see it once in our lifetime. I think we will remember the anecdote that you shared with us. With this, I would like to close today's session. Praneeth, your closing comments about what we discussed today and what we have achieved so far.
Yeah, it is definitely an exciting day today that we could complete 100 episodes. There were at times where we were struggling to find topic and attendees, but we keep going back to the intention where we started with. Also, the words of encouragement and wisdom from Dr. Somaraju sir of doing this session, even if there is no audience. That was probably one of the important driving force to continue. And with this, we are here, and I believe we will be continuing it for quite some time, as long as there is juice left in. Most importantly, rather than continuing, there is kind of a personal objective here where it made us a better physicians in treating the patients better. The uncomfortable feeling of knowing these gray areas is gone. So definitely for me, the weekly huddle has improved me or improved my confidence in the way I practice. Coming to the session today, again, this is a gray area, and I believe there are still a lot of things that we need to learn, but few carry home points that I should highlight is that if counts are more than 5,000, probably a workup is necessary and should be done by a person with expertise, like a physician or a hemato-oncologist, to evaluate the cause. Allergies are common, and equally so are parasitic infestations. India is an endemic country, and even though we do not see them, it is still worth treating them empirically with anti-parasitic agents. So deworming is probably something we all should uh, learn and practice it. It may not harm, but probably definitely helps in a lot of people. And these detailed history in terms of their occupation and their exposure to books, etc., probably will help us understand where they are getting these evaluation. These are the things that I could learn from today's session, Anup. And it's been a happy journey so far.
Thank you, Praneeth. And I can pretty much assume that this is the lowest census that we are going to get, with Dr. Somaraju and Dr. Shankar being a constant source of support for us. And if we can work with this census, I believe we can work further as well. I don't think it's going to get lower than this. So thank you all for being with us this entire time. We will continue this, and we will see you next Wednesday with a new topic that will be on the same time. Thank you, everybody. Thank you, Dr. Shankar. Thank you, Dr. Somaraju. Thank you, Dr. Prasad, for being in today's discussion. Good night, guys.